Oh, whoops. Hold on. Hello, YouTube. I'm just trying to get Facebook queued up here. YouTube, you're kind of crooked. All right. What is going on here? Oh, I see the problem. There we go. Hello, YouTube. Nice to see you. Ooh, just had a sparkly floater go through my eye. All right, hold on one sec. I gotta get a Facebook here. No. Oh, come on. Hello, my friend. Okay, hold on. That's not real. All right, Facebook. Live video. Hi, you guys. YouTube, you guys are on first. And let's see here. Create a live video event. Yes. I made popovers for my parents this morning. My mom didn't have a good night last night, so I couldn't start right away. All right, live IC, BPS, Hunners, pelvic pain. How are you guys doing today? Am I doing this right? Hold on. Wait. Something's wrong. Okay, live video. Go live. All right, connect streaming software to go live. I can do that. Let me make sure my sound is set up. Audio, nope, gotta set that up. Okay, no, that's wrong. Wait, where's my microphone? I don't need that plugged in. Is this gonna be one of those days? Hold on. Oh, come on now. Ah, there it is. Whew. No. There it is. Okay. Let's not scare Jill, for goodness sakes. Start streaming? Yes, we're streaming. Okay. Ah, what is my video about? All right, there we go. All right, almost. Thank you guys for hanging out. Okay, save. I barely put makeup on too, although it got in my hair, darn it. All right. Are we good? We're good. Oh, okay. Holy moly. Hi, YouTube. All right, sorry. Been a busy morning here. I'm all scattered. I also walked for about 4 miles this morning. So things are, a typical day. All right. Looks like we're good. I get my hair out of my face. Okay. Hello, everybody. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, October 2nd. I love the fall. I don't know about you, but I love the fall. I love Halloween. I love that we're resting now. And so I hope that you are enjoying the first fall like we are. I mean, it was cold last night. Oh, I got to wear a jacket. I don't like the heat. I like it when it's a little bit cooler. I like the seasons. Hi, Ann. All right, YouTube, you guys, let me know how you're doing. So I'm the National IC Support Group Leader. I do these meetings. I try to do them weekly. Sometimes I do them. It just depends upon the chaos that's normally happening in my life at that point in time. My purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you. I don't want anybody to demean you. I don't want anybody to insult you. I don't want anybody to tell you that IC is all in your head, because it is not all in your head. IC is treatable. And we have a lot of blessings now that we didn't have when I was diagnosed 30 years ago. We have doctors who are better trained. We have guidelines that are outstanding. We now understand why patients are not responding to bladder therapies. We understand that a one treatment fits all approach doesn't work. We now are very clear about why patients get IC, IBS, vulvodynia. Right now is the International Pelvic Pain Society meeting. Today is the last day, and I will be diving deep into those videos, because that is the group which is leading the way, the International Pelvic Pain Society. That is the one that has really helped us understand why chronic pain conditions occur, why patients get IC, IBS, vulvodynia. Of course, that's not everybody. That's just a small population of us. But for those of us who have lived that life, to finally have some answers and to finally have the correct treatments is really, really powerful. So anyway, when I do these meetings, I normally do like a 30-minute little educational thing, and then I'm happy to take your questions. Sometimes I go off and do a lot. Sometimes I don't. We'll see. Here, I'm trying to fix the camera for YouTube. I am simulcasting. If I'm looking over here, I'm looking at YouTube. If I'm looking here, I am looking at Facebook. So we've just finished IC Awareness Month, and it was exactly what I thought it was going to be this month. A little bit pretty subdued, but I would expect that, because we're all coming out of COVID right now and dealing with the long-term stress of that. So it is what it is. It's good. I always want to make sure that we acknowledge on the last day of IC Awareness Month those blessed angels who helped us along the way. And that includes doctors that we have lost, researchers that we have lost, support group leaders that we have lost, and patients that we have lost. So I want to take a moment and just acknowledge the tremendous gift that Dr. Dan Burkhoff gave us. He was a doctor who specialized in pain. He flew out to California and was my keynote speaker at our Pain Patients Bill of Rights conference many years ago. We lost him tragically. Dr. C. Paul Perry, who was a founder with Dr. Howard of the International Pelvic Pain Society. I want to acknowledge my dear, dear friends, Diane Manhattan, Evelyn White, and Michaeline Franklin, who were all IC support group leaders who helped me along the way. And we certainly want to acknowledge those IC patients who we have lost for one reason or another. You are loved, you are appreciated, and every single day we try to honor your legacy. Every single day. I always say I have an angel sitting on my shoulder, and that is Diane. Whenever I have a question about what would you do, Jill? What would you do in this circumstance? And it's always, what would Diane do? And what was the real blessing is that here, it shows that regardless of our background, regardless of our education, regardless of our race or religion, that we create powerful friendships. And Diane and I were very opposite. And she did not go to college. I went to college. But our stories were very, very similar. Our passion was very, very similar. And we worked together to build the IC Network Support Forum. So blessings, blessings, blessings. Thank you, thank you, thank you to all of our angels up above. You're so greatly appreciated. Hi, Goldie. Nice to meet you. Okay, so I just did a couple of days ago. I did a new TikTok, and I want to go over the TikTok with you because I think it's real, and I want to hear your feedback. And that is, what are the 5 things? What are the 5 things an IC patient should never do or should not do? And so here was my 5 things. Number 1, I would never, ever, ever let a doctor put any medication inside my body, in my bladder, without first asking what it is. What is it? What is it supposed to do? How is this going to make me better? What are the risks? What are the benefits? One of the things that kind of enrages me is talking with patients who let's say a newly diagnosed patient going to a new doctor for the first time, and they want to do what we call a clean catch urine specimen. So they use a catheter, they drain a little bit of urine out so that they can send it off to labs. That's fine. But some patients have been given a treatment with their knowledge. And I'm thinking of several patients that I've worked with who literally, before they even saw the doctor, were given a DMSO treatment or silver nitrate or chlorpactin. That you're laying there, that you think they're giving you a urine culture, a urine sample so you can do a culture, and then they put something in your bladder that hurts like hell? No. Do not ever let that happen. You are always going to ask, what are you doing? What is it? What is it supposed to do? What are the risks? What are the benefits? This is about informed consent. And it's important that you remember, we subtype now. We very clearly understand that there's different patients. Some of you have bladder wall driven, some of you have Hunner's lesions, some of you have chronic fungal or viral infections, some of you have pelvic injuries, some of you have central nervous system injuries. We know a one treatment fits all approach does not work, period, end of story. So there is no excuse for anybody giving you a bladder treatment without first doing the examination. Okay. Also remember too, in the old days, they used to strip the bladder wall off with silver nitrate or chlorpactin. We call those bladder strippers. The theory was, okay, if you slough off the old damaged layer of the bladder, a new layer will grow. Well, we don't do that anymore. Those are not even suggested or discussed or mentioned in our treatment guidelines, and they haven't been for a decade. Yet there are still some doctors who are doing that. So again, what is the med? What is it supposed to do? What are the risks? What are the benefits? You can say no. You can say, I want to do my research first. Let me go home. I want to learn about it, and then we can come back and talk about it and maybe do it, right? Okay. What's the second thing I would not do? I would never, ever, ever, ever agree to a hydrodistension with cystoscopy in the doctor's office. That is meant to be done as an outpatient procedure under anesthesia. Why? Because what's the most painful thing you can do to the bladder? Stretch it. Stretch it. Here, hold on a sec. We got somebody here on. All right. So, and worse, if they do a biopsy. I was working with a patient like literally 2 weeks ago. The doctor did this and a biopsy of her bladder without anesthesia. And of course, she was screaming bloody murder. And the doctor was like, oh, that's not that bad. Be quiet. No, don't be quiet. It should be done under anesthesia. If you are going to do it under anesthesia, there are a couple of other things I think you need to be aware of. Number one, you're going to ask the doctor, okay, what method are you going to use? You're going to use high pressure or low pressure? Because now we use low pressure. We now know that high pressure can rupture the bladder. What are you going to do if you find Hunner's lesions? Are you going to treat them? If yes, how are you going to treat them, right? I've talked about that before. Goldie, and Goldie, bear with me here because I'm probably freaking you out a little bit. Give me a moment. Let me get through this, and then we'll come back, and I have some very, very specific things I want to say to you, okay? Okay, number 3. Okay, what was my number 3? Hold on a sec. Oh, I would never keep taking a medicine that isn't working. Our guidelines are crystal clear. If you're not responding to therapy, if you're getting worse rather than better, stop what you're doing, take a step back, revisit the diagnosis. Back in the old days, the only thing we had was Elmeron. Okay, and people took Elmeron for years and years and years and years and years. Some patients ran out of money. And ironically, when you ask them, did it help you? At least one sweet little old lady that I was working with said, no, didn't help me at all. Then why are you keep taking it? We want to respect the fact that funds are limited and your time is limited. We don't want you to waste time doing something that isn't working for you. Number 4, stop adding stuff when you're not responding. Every week, I end up talking with at least one person who loves the vitamin shop. So you're already doing whatever meds your doctor has given you. And then you go to the vitamin shop and they go, oh, hey, you got cystitis. Let me give you some cystitis stuff. And before you know it, you've got cranberry, you've got D-mannose, you've got PACs. Oh, you've got marshmallow root, you've got slippery elm, you've got, you name it, you've got it. And then, of course, you learn about the supplements. So then you go, okay, I'm going to try some supplements. So let's try some aloe. Let's try some Cysto Protect. Let's try some Bladder Builder. And before you know it, you're buying $500 worth of stuff a month and you're taking it all. And you probably have an upset stomach taking it all. Stop it. Stop it. More is not better. It's very important that you take a step back and ask yourself, why would this not help me? So if, for example, you're doing Elmeron or you're doing Bladder Builder or Cysto Protect, one of the, either the medication which can coat the bladder, which of course we really don't talk about very much anymore because it can cause eye disease. But anyway, we're looking at bladder coatings. So you're either doing Elmeron or you're doing Bladder Builder or Cysto Protect. But if the bladder coating isn't helping you, and you're still flaring, don't add more. Take a step back, revisit the diagnosis. What have we missed? So in my case, I first had my symptoms when I was 14 years old. I did bladder therapies off and on for 30, 40 years. Didn't work. 30 years. No, 40 years. Why? Because it was never my bladder. It was always my muscles and my nerves instead. So again, don't keep adding more and more and more. Stop and ask, why isn't this possibly helping me? And then I would not, what would I never do as an IC patient is stay with a clinician that will not answer my questions or won't see me. And this is a delicate one because you got to understand that some IC patients are pains in the butt. And I'm not saying that's bad. Squeaky wheel gets the grease. If you're in a flare, believe me, you have every right to call your doctor. You have every right to call your doctor once a day, twice a day, if you need to, until you get an answer. I mean, you can't abuse them. You can't yell at them over the phone. That would be absolutely foolish. You have the right to ask for help. But you have to understand the cultural norm of IC. When many doctors went through medical school, they were told, oh, you're going to hate these patients. They're going to be pains in the butt. They're going to call all the time. They're going to drive you crazy. The best thing you can do is neuromodulation or whatever and just get them out of your office. And so you have to understand that there are some historical perspectives that work against us. And even though we've addressed all those, we still have to understand that some doctors are uncomfortable because they can't see it and they can't feel it and they can't touch it and they don't have the skills to manage it. You may outpace the skills of your local doctor. You may need to go to a regional doctor. I did after a year. My local doctor said, hey, I've done everything I can do. I need to send you to somebody who specializes in IC. So I went from Sonoma County, California. They sent me to San Francisco to Dr. Staller at UC San Francisco. And he was much better, much more aware of the new research and new treatment protocols. And some of you are going to outpace the skills of your regional doctor. And you may need to go to a national doctor. And the point that I'm trying to make here is you deserve a doctor who understands IC, who is compassionate, who is experienced, who is knowledgeable, and who is willing to provide you the care that you deserve. All right. So those are my top 5. And my neck just did a zowie. Hold on. I'm really working on muscle tension right now. Fida says, hi, she says, thank you so much for useful info. After cystoscopy, the bleeding won't stop with every flare. Pre-leaf is not available in my country. Is there anything similar you can advise? All right. Now, we got to talk about bleeding here. Bleeding is, the great majority of IC patients do not have visible blood in our urine. If you have visible blood in your urine, if you are peeing pink or you are passing red or black blood clots, that is urgent. And it is very, very important that you call your doctor as soon as you can and let them know that you're peeing blood. If you're peeing bright red blood, like your toilet bowl is filled with bright red blood, that's an emergency room trip. And your question is always going to be, what is bleeding? What is bleeding? And at that point in time, usually you want somebody to look in your bladder so that they can try to figure out what's bleeding. And in our new guidelines for IC that came out a couple of months ago, they're really taking hematuria, especially that's blood in your urine, gross hematuria, which is a lot of blood in your urine, much more seriously. They're making a very strong point that anybody with visible blood in their urine should receive an extra workup. They should be checked for obviously UTI, which can cause that. We want to check for viral infection, which can cause what we call hemorrhagic cystitis. And we want to check for cancer because it's cancer that can bleed a lot. I had a really good picture, by the way. I love gross show and tell. Not that you want gross show and tell. I like gross show and tell. There was a really interesting picture of a bladder cancer that came through my Twitter feed that looked like spaghetti, like just in time for Halloween, right? It looked like long, skinny noodles, all kind of wrapped up like a little bowl of pasta. It was fascinating. Benign. It's benign. This wasn't malignant. It was just something that happens. You have to remember that cancer is an overgrowth of cells, that something's happened to the normal cell proliferation, cell maturation process. And so we start seeing a massive overgrowth of cells into tumors and masses and things like that. Anyway, this was that. Also saw a picture this morning of monkeypox. Monkeypox can affect down below, and it can cause a lot of swelling down below in men, exactly where you don't want swelling. I was quite impressed. It does go away after about 6 weeks, but that's very interesting. All right, let's see here. Marcia says, I'm 62 and menopausal for 7 years. Hey, we're the same age. Yay. I've been using estrogen cream for the last 6 months and Desert Harvest Sallow, and I'm worse. How are you worse, Marcia? Are you worse in the sense that you have more frequency? Are you having more pain? Tell us how you're worse. Bobby says, saw a new doctor this week. Based on my symptoms, he wants to do a hydrodistension and remove my urethral sling to determine if that could be causing some issues. Well, so for anybody who has had a prolapse, if things are starting to fall out of position, where your bladder starts to move almost through your vagina, et cetera, et cetera. So as we get older, if we suffer traumatic injury with the loss of estrogen, our muscles get weaker, things can start to move and prolapse. And if you catch it early enough, you can do Kegels, and they can start working with your muscles to strengthen your muscles to try to keep things where they belong. But if you've waited a little bit too long, or if it's just a really, really profound injury, they may need to do surgery to try to put things back where they belong. Because the last thing we want is your bladder to flip-flop over, right? Your bladder can go whoop. So now you got urine collected here and urine collected here, and the urine here isn't going to drain, and then you're going to get UTIs, right? So at some point in time, you had something going on with your urethra, and you had a sling. There's a whole bunch of baby squirrels right outside my window. Sorry, if I was looking there, the baby squirrels were running by. So the challenge with doing slings is getting the tension right. Because this is where you want a very, very experienced doctor doing your surgery, because as they move things back into position and kind of tack things up, they can go too tight. I can't demonstrate too tight. And if they go too tight, then that's going to cause more pain and discomfort. If they go too loose, the prolapse is going to continue. So it sounds like what he's trying to do is figure out if the urethral sling was too tight. Is possible. Goldie says, what is the first step to diagnose IC? Well, it begins with your symptoms. So the typical symptoms of IC bladder pain syndrome is frequency, urgency, pressure, and or pain in the absence of infection. So most IC patients suddenly develop these symptoms, and these are the symptoms you always associate with infection. You call the doctor, hey, I think I have infection. They give you antibiotics. They don't work. You call your symptoms continue. Your doctor goes, hey, maybe we should try some long-term antibiotics. They don't work. Eventually, your doctor says, maybe you've got overactive bladder. Let's give you some frequency urgency. Let's give you some antispasmodics that will help reduce frequency urgency. They're not going to work. And eventually you get that, hey, I hate to break it to you, I think you've got IC, this quote unquote incurable bladder disease. And remember, we've thrown that out. And they will usually give you the diet, give you some medication, and say, I'll see you in 6 months. Of course, we don't accept that now. Now we understand, it's important for you to understand, there's this tremendous diversity in this IC patient population. For some people, IC began in childhood. For others, IC began after menopause. Are you biologically the same? No. For some of you, IC began after chemotherapy. Well, for others, IC began after having a baby or falling on their tailbone. Are you biologically the same? No. And when we look in the bladder, we really see the diversity, because for some of you, you have big bloody wounds in your bladder that are bleeding, a small percentage, 5%. The rest of us usually have normal bladders. You might have a little bit of petechial hemorrhaging. That's all thrown out now too, because we know the test itself causes that. So you have to understand, Goldie, that we're not all the same. There's distinct groups, and the challenge with Facebook and online support groups is that you can't put apples, oranges, and bananas in the same group and think they're going to be the same. They're not. And you're going to read a lot of stories on Facebook that are going to be completely irrelevant to your unique case. So what you need to do is you need to come on over to the IC Network website and read about subtyping, so that we can find your unique variation of IC. IC is a grab bag diagnosis. It means the doctor acknowledges that you have symptoms, but they don't know why. But the term interstitial cystitis is now being thrown out in Europe. Prostatitis is being thrown out in Europe, and they are using instead bladder pain syndrome or chronic pelvic pain syndrome, and that is indeed correct. So what are our 5 subtypes? Number 1, Hunner's lesions. These are the big bloody wounds. These have now been connected to viral infections, although it can also be kind of a neuroinflammation from an underlying muscle problem. IC subtype 2, bladder wall driven. In this group, we're going to look for chemical injuries to the bladder, chemocystitis. So if you've had chemotherapy, that's going to injure the bladder wall. If you're drinking way too much diet soda, coffee, tea, that's going to injure the bladder wall. That's not a disease, that's injury. So your job is to create an environment that will support healing. Our other mini variant in bladder wall driven is going to be estrogen atrophy. So if your symptoms began after a hysterectomy, after going on Lupron, after starting a new birth control or becoming menopausal, that again is not a disease. That means that your bladder is no longer getting the estrogen it needs to produce mucus. And so your bladder can't defend itself, period. It just can't defend itself. So our therapeutic priority for this group of patients is to give them estrogen. When we give them estrogen, the bladder wall starts to produce more mucus and get stronger. It's like watching a raisin plump up and become a normal grape again. That's what happens with estrogen. Our third subtype is pelvic floor driven. These are the patients whose symptoms began after a pelvic injury. Our fourth subtype is pudendal neuralgia. These patients have a nerve injury characterized by pins and needles, areas of numbness, PGAD, persistent genital arousal disorder, and then IC subtype 5 is chronic overlapping pain conditions. These are the patients who have more than one. You've got IC, IBS, vulvodynia, TMJ, fibromyalgia, migraines, etc. If you have two or more of those, then you are in this subtype. This is my subtype. And this means that you have a central nervous system injury. So, guys, give me one quick sec. Hold on. I'll be right back. I just need to get some Vicks. All right. Here I am. No, man, there's something blooming. And I could just feel myself getting congested. Use a little Vicks Vapor Rub underneath my chin. I love that stuff. All righty then. So when you go to the doctor, Goldie, I don't want you to say, hey, I have IC. I want you to walk in prepared to discuss your symptoms. Your symptoms are a roadmap that your doctor is going to use to try to figure out what's wrong with you. So it's, are you sleeping through the night? Do you have pain? Where? Where is the pain? Is it on the inside? Is it on the outside? When is the pain the worst? Before you pee or after you're done peeing? Are there any weird, unusual symptoms? Do you have sciatica? Do you have pain in your feet, pain in your knees, pain in your hips? We have to look at the totality of the pelvic floor. Of the pelvic cavity, including the pelvic floor. I wish I knew what was blooming. It's fine until I came in here. It might be, oh, you know what? I bet it's a freaking pine trees. I'm very, don't pine release their pollens in the fall? I bet that's it. Oh. Marcia says, my urethral pain is so much worse. Sometimes the pain feels like it's radiating into your vagina. So, Marcia, have you been putting the estrogen at the entrance to your urethra? Normally, urethral pain from estrogen atrophy, number one, it's very common. I've had it myself. You rub a pea-sized drop of that estrogen right into the entrance of your urethra. Have you been doing that? Hold on. Facebook is not cooperating. I have to pop out the discussion so I can see it. All right. There we go. Hello, Caroline from England. Hi, Kayleen. All right, now I can scroll back. Sorry, Facebook and YouTube, feed up. I haven't forgotten. Give me a moment. I'll come back to YouTube too. Goldie said she had TNBC last year. All is well now. Any suggestions for atrophy since I can't take the hormones? It's actually controversial. I did not have the hormone type cancer. Well, oral hormones, oral estrogen are indeed present a greater risk of cancer, but topical hormones, a cream that you would use on your vulva at your vagina, is research studies have found to be remarkably safe. And so that's normally what we do for estrogen atrophy, because that's the perfect thing that you can give to that skin to get that skin strong again. So again, oral is considered risky. Topical is considered very safe. All you need to do is Google topical estrogen safety, and you can see that research yourself. You can also try something like V-Magic. Where is it? All right, where is my V-Magic? Is it under? So V-Magic is like a little tub of a very light coconut, avocado, sea buckthorn oil that really mimics human mucus. And you can use that. You know, you have to remember, listen, when you have estrogen atrophy, your skin has no defenses anymore down there. So one of the classic symptoms of estrogen atrophy is burning while you're peeing. We call it urine burn, where literally your urine feels so hot, like it's burning your skin. It's not burning your skin. It just means your skin is dry. And so using something that has a bit of an oily base like V-Magic or coconut oil throughout the day, or at least once a day, will give that skin some protection so that urine isn't triggering it. Nato says, or Nato says, if your urethra hurts, it can also be the pudendal nerve. Yeah, it could be. But pudendal nerve symptoms tend to be pins and needles, electrical, pain with sitting, pain with standing. I mean, I have a partial pudendal neuralgia in my left butt cheek. The last time I had some pudendal neuralgia from tight pelvic floor muscles, it manifested in a very, very different way. I started getting pin pricking along my labia, and it started towards the front, and over a period of a week, it kind of moved all the way down the labia, all the way to the back. And it was like I was being poked randomly with needles, one side, then the other side, front, back. And I mean, that was just this whole drama with my doctors. They thought it was yeast. It wasn't. They thought it was eczema. It wasn't. It turned out to be a pudendal neuralgia. And they sent me back to pelvic floor physical therapy to loosen the muscles, which were squeezing the nerve. Holy hell, Renee. Renee says, I had cystitis and everything prolapsed. You had a total pelvic rebuild, no mesh, burning most days. My doctor was well known in the Atlanta area. I now have pain all the way through. I can feel a bulge after each bowel movement, more burning after bowel movements. I had 2 surgeries in 6 months in 2021. You know, you're trying to go to a national doctor. You have a bulge in your vagina. Yeah, honey, I'm so sorry. You know, we always hope and pray that surgery can fix something that's very complex. But as the AUA guidelines say, you have to have a very, very, very skilled doctor, experienced doctor doing any of these surgeries, including IC bladder surgeries, which are rarely done, but occasionally they are done. I wish you luck. Who are you going to go see? Hi, Kayleen. All right, Fida here on YouTube said, is there a cure for a viral infection in the bladder? Any medication? Well, we have antivirals. We have antiviral medications that are often used. Lysine also is something that interferes with viral replication. So for those of us who have had herpes, whenever I thankfully, I don't get cold sores very often, but I'm well known to get canker sores, and which is also herpes, which pretty much the great majority of the population in the United States has. You usually get it as a child from somebody kissing you. If I ever start feeling the little pins and needles on my lip where that would happen, I use a lysine lip chapstick, and it's amazing how good it is because lysine interferes with viral replication. But once you have a virus, you have a virus. It's going to live in your body. Generally, it lives on nerves and it's silent, but sometimes it gets activated again. So that's why the chickenpox virus is associated with shingles. That once you have it, you have it. We just want to try to keep your body as strong as it can be so that if it does turn on again, your immune system will turn it off. Jessica says, can boric acid suppositories like Hyalofam help with repeated BV infections? I don't see any harm in it. Although I'm sure somebody would say, hey, let's not mess with a viral biome. You know, I mean, not not the viral biome, the bacterial biome, the normal vaginal biome. We are paying a price now for the massive overuse of antibiotics and what that's done to our gut and what that's done throughout our body, including in the vagina. But that's not my area of specialty, hun. I mean, normally boric acid suppositories are suggested for people with overgrowths of fungus. I'm not sure how good a boric acid suppository is going to be with the bacterial vaginosis. I just don't know. Fida says pre-leaf is not available in your country. Is there anything similar? Yeah, Tums. Just use some Tums. Or you can do a quarter teaspoon of baking soda in a glass of water. All you're trying to do is alkalinize your urine. That's all it does, is it alkalinizes your urine, reduces some of the acid that's in your urine that's irritating. Marcia says, I also have fibromyalgia and vulvodynia. Okay, so Marcia, for you, then part of your therapy has to be calming and soothing your central nervous system and getting out of fight or flight. With the connection, now we know, and all the research with chronic overlapping pain conditions, which has been fabulous, underneath all that is a remarkably sensitive nervous system. It's a nervous system injury. And we call it a central nervous system maladaptation. And so therapeutically, what we have to try to do is we have to try to calm the central nervous system, and we have to get your brain out of fight or flight, because the odds are you have anxiety. Pain that is accompanied by anxiety will be intensified by the brain. Pain that is accompanied by laughter will be minimized by the brain. Nobody is saying this is all in your head. Not a single person is saying that. Not a single person is saying this is mental illness. What we are now saying is it's injury. And, you know, I am listening to right now. Oprah has done a fabulous documentary with Prince Harry on the effects of trauma in children and how the nervous system changes. And this has been very compelling for me because I really want to try to understand the person that I am today based upon what happened to me when I was younger, because I have all those sensitivities. I did have all those. And there's a part of you that thinks you're damaged goods, and there's a part of you that thinks that there's something fundamentally wrong. But there's a very important distinction you have to make. It's not what's wrong with you, it's what happened to you that matters. And I would encourage anybody who has multiple pain conditions and or anxiety disorder, it's on Apple TV, watch it. Watch it. It's like 5 episodes, 6 episodes. And one of the most interesting, they follow patients around the world who are struggling with different types of trauma and how that changes them. And one of them is a young boy from Syria who had to flee Syria after his brother was blown up by a bomb, and watching how therapists were working with him to make sure that he was not living in that grief and sadness. I mean, how can you not, right? But it's about um, um, what the counselor, who's fantastic, was saying to him is, think about the good moments. Think about the sweet memories. Your brother doesn't want you to remember the bad stuff. And anyway, it's a book. Really, honestly, was not much of an over. I mean, I think she's amazing. And it's a book called What Happened to You. And it's about, again, kind of understanding childhood trauma and how that changes things. And also the comfort. How does a child get comfort? A child gets comfort. Remember, we're talking about sensory information, right? So we're talking about the most primitive part of your brain monitors your senses. What do you see? What do you hear? What do you smell? What do you taste? There's no cognition happening in this part of your brain, but that is the part of the brain that's driving chronic overlapping pain conditions. And so therapeutically, we're always trying to give you good, safe sensory information to tell your brain you're safe. And anyway, the last chapter that I was listening to, they were talking about how an infant brain is built. And it starts at that primitive part, and then it just slowly blossoms out as that infant becomes a young child, and 50,000 or 100,000 new nerves are created every day, right? It's just amazing. So how does that infant get comfort? It's from their sensory information when mama and dada's holding. And what is that infant smelling? Is it a good smell? It's the smell of mom. What are they feeling? The touch of a hand. It's just amazing, amazing new research. This helps me understand why my favorite memory of my mom is sitting at church in her lap, my head resting against her breast. I mean, I was like 3 years old, and she was singing, and I could hear her singing through her chest wall. And I still, it's just like, that's pure and utter joy for me. So anyway, I'm really trying to understand this central nervous system trauma. So we know that if 80% of the children who have chronic overlapping pain conditions eventually happen, they suffered a major physical injury. And then for the other 20%, it's a history of abuse or bullying. If it's primer and it's going to burn, that's true. Hi, Katie. Jody says, do you know of a pelvic floor specialist in Spokane? My 20-year-old granddaughter just had laparoscopic surgery for endometriosis. Her doctor said she has very tight pelvic floor muscles. Good on that doctor for noticing that. There's a great website, pelvicrehab.com. That is the master list of pelvic floor rehabilitation specialists who are certified. So let's go there right now. So I just searched for the city of Spokane. You have 2 certified pelvic floor physical therapists in the city of Spokane. One is Christy Frazier, and the other is Joyce Binford, Binford. So go to pelvicrehab.com. Hi, Alexandra. Nice to see you, hun. Goldie says, I'm 73. My symptoms started after 65. Yeah. So Goldie, also you need to Google genitourinary syndrome of menopause, because if they started after 65, in all likelihood, it's the loss of estrogen changing your skin, changing your bladder directly, because your bladder is estrogen dependent. Katie said, my doc orders estradiol 1 milligram cream applied 2 clicks 2 times a week. I've not yet started it. It's good stuff, hun. That's what I use. Goldie said, I was told it was pudendal neuralgia. I don't have the common nerve symptoms. Well, pudendal neuralgia characterized by pain when you sit down, that gets better when you stand up, pins and needles, areas of numbness, and PGAD. If you don't have any of those symptoms, it's not pudendal neuralgia. Kayleen said, I got the lidocaine gel and it hurts so bad. Either it's too cold or my vagina catches on fire. Girl, I want you to do the power pose. And by the way, that TikTok you did last week was awesome. So what's the power pose? The power pose is standing like Wonder Woman, standing with your legs spread, your hips, your hands on your hips, your shoulders back, looking straight ahead. And what that does is that triggers the production of testosterone in your body, and it will make you a bit stronger and a bit more confident. I don't understand why the lidocaine gel would be burning you, hun. I mean, doesn't the area get numbed like within 10 seconds? Ruth says she uses the estradiol insertable tabs. Jill, do you think the Replens vaginal moisturizer is okay to use? Sure. But it's not going to, I mean, it will help soothe that. It's not going to soothe that skin. It's just going to moisturize that skin. Kayleen said, I have the prickling feeling randomly too, and it's really tight muscles around my left butt cheek too. You know, like I truly believe for so many of us that we have shared past lives together. Kayleen, I'm telling you right now, you feel like a sister. I mean, so many of you feel like sisters and brothers to me. You do. You really, really do, guys. Marcia said, my symptoms of urethral burning so much got worse after I had COVID in 2020. So that's challenging because that's COVID cystitis. COVID cystitis has been found in the bladder. It's that cytokine storm that reaches the bladder and irritates the bladder so much. And that cytokine storm flare can last for months and months and months and months and months. Goldie says, so would the oral lysine maybe help viral? It could. I mean, there's no harm in lysine. Although, listen, obviously I'm not a doctor. I can't give you medical advice. You need to do your due diligence and read about it. But lysine is very commonly used for patients who struggle with other viruses. And there was some early research of lysine with COVID also. And I haven't read that recently. Goldie said, Cipro messed me up when I got it for an E. coli UTI at the age of 65. Yeah. Goldie, it's important that you understand that because your skin is now more fragile, because it doesn't have the estrogen, it's not going to be able to defend itself as well against bacteria. You know, normally your bladder, when you're younger, has a really thick coating of mucus in it that acts as a barrier that makes it hard for bacteria to infect you. But unfortunately, you and we are now estrogen deficient. That means that normally thick layer of mucus is much, much thinner, and it's much easier for bacteria to get through it to infect the skin. If you keep getting infections, especially E. coli infections, then you're going to want to do a proanthocyanidin supplement, a PAC supplement like Prevent, PRVNT is a good supplement for patients who are struggling with genuine recurring UTIs. Bobby said, is there a way to get out of fight or flight? Absolutely. Mind body medicine. I can get you out of fight or flight in 3 minutes. You want to do it? Let's do it. Okay, so let's do it. So bear with me here. For those of you who don't have fight or flight, you don't have chronic overlapping pain conditions, just bear with me. But you can do this too. And I want you to learn this technique because it's really, really good if you have children who are scared of anything. children who are struggling with anxiety to go to school, things like that. So let's do I Spy, okay? Let's do I Spy. I love this technique. It works every single time. We are going to prove a child, pick something that you just like. So for me, I'm going to pick this. I just bought this yesterday. I love Halloween. Okay. So let's look at that for a couple of seconds. Now we're going to take a deep breath. Deep breath in and a deep breath out through your mouth. Okay. Now we're going to go to our next sense. Can you hear anything besides my voice? Is there traffic? Is there a heater, a furnace, or an air conditioner on? Is the wind blowing? Just stop for a moment and just engage that sense. Can you hear anything else besides Jill talking all the time? And I can't. Everybody's quiet, but that's okay. Deep breath in, deep breath out. Can you smell anything right now? Now we're going to the sense of smell. Can you smell anything? I can smell, I made popovers for breakfast this morning for my parents. So I can smell the equivalent of muffins. You got any other smells in your house? And this is where aromatherapy really helps. Okay, let's take a deep breath in. Can you taste anything? Are there any flavors in your mouth? I have flavor of strawberry banana. So take a moment and ponder flavors. Deep breath in, deep breath out. And last but not least, I want you to take your hand. Now we're going to engage the sense of touch. And I want you to rub it up and down your leg. Just take a hand, rub it up and down your leg. Okay? No threat. Feels soft. I'm wearing some of my favorite workout pants. It feels great. Okay, deep breath in, deep breath out. Okay, now we're going to go to the fun part. If you could look at anything that would put a smile on your face, what would that be? For me, a monarch butterfly, or the ocean, or a squirrel going across the roof next door. Think about something that would make you smile, that you would love to look at, a waterfall. And let's just go there for a couple seconds. Deep breath in through your nose. Deep breath out through your mouth. What could you hear that would put a smile on your face? What's your favorite thing to listen to? It could be a child laughing. It could be your favorite music. It could be ocean waves. Pick about something that you love to listen to. The fall of a waterfall. And I want you to close your eyes, and I want you to visualize that you're there. And for me, I'm on the beach in Hawaii, and the waves are coming in. And the birds, the pelicans, and the seagulls are flying overhead. And there are children running down the beach laughing and playing. Let's go there for a couple of seconds. Deep breath in through your nose. Deep breath out through your mouth. What could you smell that would put an immediate smile on your face? What's your favorite thing to smell? For me, every single time making hot cinnamon rolls in the oven, or coconut. Or when I was a child, I had a little pillow that I carried with me that smelled like maple syrup. Think about your favorite smell. It could be your lover, could be a baby. Close your eyes and go there and just smell that smell. Okay, deep breath in, deep breath out. What could you taste that would put an immediate smile on your face? What's your favorite thing in the world to eat? I don't care if it's IC friendly or not. What is your favorite thing in the world to eat? Again, for me, hot cinnamon roll every single time. So I want you to close your eyes and I want you to visualize that your favorite chocolate cake, a brownie, coconut, ice cream, cup of coffee. Pick your favorite thing in the world to eat. Close your eyes. It's in front of you and you're holding it. Cup of coffee, you're smelling it. It smells so good. Deep breath in. And a deep breath out. And last but not least, we're going to go to the sensation of touch. What could you touch that would put an immediate smile on your face? Would it be a dog or a cat? Would it be ruffling your child's hair? Would it be fresh cotton sheets that you're putting on your bed? Think about what's your favorite thing in the world to touch. Close your eyes and let's go there. Deep breath in and a deep breath out. All right, how do you feel? You got a smile on your face? I'm going to bet that the great majority of you have smiles on your face. Why? Because we have just short-circuited fight or flight. We have just proven to your brain there's nothing to be afraid of. We have given it good, safe, sensory information. Now, I just rebuilt a good portion of the IC network. I put a whole new section on mind-body medicine in there, completely updated all the FLAIR resources in there. And hopefully you'll find some things that you can do in there too. One of the techniques that's very interesting, they call it, what do they call it? It's where you flutter your lips as you're breathing, like a buzzing bee. Like that does something. It's quite interesting. You just have to remember that whenever you have a negative thought, you trigger fight or flight. And the problem with anxiety disorder, and you can't kid a kidder because, hello, I've been there. In fact, I'm back in an anxiety, although I'm better, but every now and then anxiety comes back up and then it goes back down and it comes back up and it goes back down. Really, again, it depends upon how safe your brain feels. You have to learn some really good new anxiety management tips too, because we want to stop the negative thoughts. The challenge with anxiety disorder is you have negative thought after negative thought after negative thought after negative thought, and then you get stuck in massive chemical overload. You're swimming in adrenaline, which is what makes you feel so unsettled and what drives panic. So we have to have a technique that will stop those negative thoughts. And I have a video on our website that will teach you exactly how to do that. It's called IC and Anxiety. I'll do it here if you want to learn about it, but let's keep going. And Renee here says she uses Calm, Daily Calm, and the Mindful Moment. Calm is an app, right? I need more. I am being forced right now to accept the fact that the last couple of years have been stunningly stressful, and I think we're all being taxed. We're all being taxed because of the pandemic and other stuff. And so it's kind of like an opportunity to get back and care for yourself a little bit more than we have been. We tend to push through all the stress. And at some point in time, you're going to get high blood pressure like I did a couple months ago. And my blood pressure is fine now, but you got to listen. I did something else yesterday, I'll tell you, because I'm really trying to understand the impact of childhood trauma, right? And yesterday when I went for my walk, I actually walked down to my old school where I had all the trauma happen. Only this time, I walked down holding the hand of my younger self. So I was the old 62-year-old Jill holding the hand of the 8-year-old Jill and the 9-year-old Jill, and saying all the things I needed somebody to say to me back then, like, you're going to be fine. Look at how strong you are. Look at what you do as you get older, right? And I was stunningly healing. That was a real big moment for me. I don't know why I did it. I just was like, I didn't want to walk down there. I had such bad memories. So it's like, do it. Retrace your steps, go back and address the child that got hurt so badly. And I did it. And I was so much better for the experience. All right, Anna here. After 3 years with Professor Monley and on different antibiotics, I do not see much improvement, and actually I've been having extremely strong pain in the ovary. My problems intensified dramatically 1 year after that operation. Well, remember, we just don't have the data to support Professor Maloney's position that I see patients have chronic UTI. In fact, the biome studies continue to find that our bacterial biome is absolutely normal, just like the biome of somebody without bladder symptoms. What's different is our fungome, that some patients do have an overgrowth of fungus, and some patients might have virus. But the presence of candida in urine, which is going to be a byproduct of using too many antibiotics, is strongly associated with bladder pain. Katie says, my pain intensifies at 4 a.m., which is now leading me to the recliner. I go to bed at 10. 6 hours, huh? Interesting. Katie, is your pain positional at all? Is it better when you're on your side versus on your back? When my pudendal neuralgia was really bad, I could not sleep on my back. I would have very, very strong pain by my SI joint. I had to sleep on my side or sleep on my stomach. But I'm sleeping in a recliner now too. It is what it is. Anne says she likes my shirt. Thank you. Alexa says, going to her first pelvic floor session on Tuesday. Yay! And you're going to get some bladder rest, but I do need to take it but do you need to take a supplement for the rest of your life? No, absolutely not. That's very important that again, guys, in the old days, everybody was saying incurable bladder disease, you're going to be on the meds for the rest of your life. We don't do that anymore. We haven't done that for a decade. I see for many of us as injury and or trauma. And if we can heal the underlying injury, then the odds of you needing stuff in the long run is much, much lower. So we have to start with your anatomy and really understand what your anatomy is. If you have a muscle injury, then you're going to need physical therapy. And the physical therapy should help you tremendously. If it does not help, we've got to take a step back and figure out why your muscles are so tight in the first place. Then we have to look at bones. Do you have a bad hip? Do you have a bad SI joint? Do you have a bad knee or a bad foot? So we're really, again, guys, it's a very exciting time because far more patients are being treated successfully. And so how do you figure out? You reduce the dose. So let's just say you've been on Cysto Protect for 2 years and you're not sure you're feeling pretty good. You're not sure if it's helping you or not. Reduce the dose. If you're taking 4 a day, do 3 a day for a week. See how you do. Go down to 2 a day for a week. See how you do. Go down to 1 a day. If your symptoms don't come back, then your bladder's in great shape and you don't need the supplement. Eva says, what's the main difference between interstitial cystitis and overactive bladder? Because many people get misdiagnosed. The big difference is in the sensation of urgency. So patients with IC and overactive bladder are going to have frequency, urgency, pressure, or pain. Well, except overactive bladder patients often don't have the pain, but they're struggling with the frequency, urgency. If you're running to the bathroom urgently because you're in pain and you want to get rid of the pain, that's IC. If you're running to the bathroom urgently because you think you're going to leak, that's overactive bladder. So it's the symptom of urgency that matters. Mary says, what can you do with IC pain when you've lost a family member? In our case, our son, from sleep apnea. Oh, honey, I'm so sorry. Mary, I'm so sorry. My husband is having a lot of anxiety, and when he shares it with me, my pain ramps up. Oh, you know, grief is a terrible thing. Losing somebody that you love and is such an important part of your spirit and your soul is just with the greatest stress we can go through. And working with a grief therapist, I think, would be being in a grief support group that will give you some support and give you some skills, I think is absolutely the right thing to do. And everybody grieves differently. Some people don't grieve for 5 years, and all of a sudden it hits them 5 years later, and that's when they start crying. Other people, you know, they're stuck for a year. Okay, something's cutting my tongue. Okay. And I make no secret of it. I'm caring for my dad will be 100. Oh, and I need help, guys. I really, 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 really need your help. I want my dad to have 100 birthday cards to open on his birthday. Would you be willing to send a birthday card to my dad to me? I want to get as many birthday cards as I can for him, because I still don't think we're going to be able to get together with family. I don't. I've got one branch of the family where everybody's sick and another branch of the family that isn't traveling right now. And I really want to celebrate his birthday. So, Alexa, thank you. Thank you. I will, I don't want to put my address in publicly on YouTube or on Facebook, but I will post it. Okay. Or if you email me, icnetwork@mac.com, I'll email you back and my address. So, Mary, I just want to say this. So I'm living with that. That's one reason why I'm under stress, is because I know that that's going to happen sooner rather than later for me personally and intimately. I think it's very, very important that we think about ways of honoring those that we have lost, especially on anniversaries. So if your son, for example, loved animals, I would dedicate a day to raising money for his favorite charity. Or if he believed in supporting the homeless or in food banks, anything at all like that. Pick something that you know would just tickle them. Absolutely tickle them that you're doing this in their honor. That is absolutely the best way, I think, that we can transition some of that profound sadness to joy and pride and honor. YouTube. Lindsay, I also think exercise is just so important. The lady who makes our heating pads, I saw her yesterday. We have handmade pelvic heating pads that are fabulous. I should go get it. I use them like literally every day. She started walking a year and a half ago, and she looked incredible, like 20 years younger. I've only been walking. I've already lost weight, and I feel way, way better. I did a massive hood that's doing that. And so I would be doing something that would be giving your bladder a little bit of extra protection, a little bit of extra coating. So I would probably be doing something like Cystomend, which is the strongest coating formula out there. And I would be doing maybe Peora, Peaora, to calm some of that pain down. Hi, Gay. Crystal's having trouble with the catheter. Why? What's going on with the catheter? icnetwork@mac.com. If you email me, I will email you back my home address. Theta says, God bless your father. Thank you. Oh, you lost your dad during COVID. I'm so sorry, hon. I'm so sorry. That was my, that's one reason why I've done nothing in 2.5 years, really. I haven't gone to any conferences. I haven't gone to movies, anything, because I did not want to bring COVID back to my elderly parents, right? Right. Okay, so there was a couple of new research studies. Okay, I see your emails. Okay, so hold on a sec. There was a couple of new IC research studies that were very interesting that I thought I would share with you today. Okay, don't want to do that one yet. Hold on. Is that it? Oh, yes, here it is. Here it is. Here it is. Okay. So, do you have super sensitive skin like I do? Like literally you can't wear wool. You can't, like if I wear wool, I have to wear something cotton underneath it. So we have been tracking now for the last couple of years a condition called small fiber polyneuropathy. It basically means that the smallest nerves in the skin are more sensitive. And so the first paper came out like 2 years ago, did an article on it. And it's one way of kind of validating that, yes, you and I, yes, we really do have more pain because the smallest nerves in our skin are actually far more sensitive. So we call this small fiber polyneuropathy. So we have a new paper that came out on this. I got it 3 days ago. And here, hold on a sec. Oh my God, I did not expect to see a picture of I won't even tell you what that picture is of on this urogynecology website. Okay, yikes. And yes, let me agree to the cookie policy. So the pathophysiology of IC is imperfectly understood. Recent studies reported that small fiber polyneuropathy is common in fibromyalgia, a condition commonly found in IC patients. Again, in the chronic overlapping pain condition group. What do we look for? A wicked sense of skin. I mean, a wicked sense of smell and very sensitive skin. So in this study, adults diagnosed with IC scheduled to undergo a hydrodistension were recruited. A skin biopsy was obtained from the lower leg, where they did something called an intraepidermal nerve fiber density measurement. Small fiber polyneuropathy status was determined by comparing the nerve density with normal values, yada, yada, yada. Okay, the results in this large cohort of patients, this was 100 patients, 31 were positive for small fiber polyneuropathy. Intradermal nerve fiber density was below the median for age and sex in 81% of patients. Hold on. Okay, I want to what intraepidermal nerve fiber density was below the median for okay, I get that. 1/3 of the small fiber patients reported other chronic overlapping pain conditions such as chronic fatigue syndrome. Small fiber polyneuropathy positive patients reported fewer allergies. There was no significance in the difference in bladder capacity or Hunner's lesion status. Small fiber polyneuropathy is common as a common finding in patients with chronic overlapping pain conditions. Okay, so let's put that into context here. So remember, we're all trying to understand why chronic overlapping pain conditions occur. What we know from the research is that it is a central nervous system maladaptation, that the nervous system has been injured. And Prince Harry actually said that this is injury. We don't think of this as disease, this is injury. So either there was a major physical injury or there was physical injury or perhaps bullying and or emotional abuse. Okay, thank you, Alexa. I got your email. I will email you guys back. So the question is, how does that injury manifest? So generally what happens is at the site of the physical injury, the nerves in the area become injured and sensitive. And then there's neural crosstalk, so the nerves nearby pick up that sensitivity. So that gives us regional nerve sensitivity. The question is, why is there body-wide sensitivity? I don't have the perfect explanation. I'm getting there. How would I describe that? Oh, I know how I would describe it. Okay. When you are in fight or flight, the way your brain functions changes. Different parts of your brain light up. Some areas become bigger. Some areas become smaller. Some areas start talking very quickly. Other areas go very, very slowly. It is how that central nervous system responds to long-term chronic stress. And so there's a ripple effect of that. And that's what all the research is trying to understand now is how does that manifest throughout the body? I think it's interesting. Now it at least explains, all this extra skin sensitivity. And most importantly, the wicked sense of smell. So many of you, when you call me and we do the subtyping and I go, so do you have a wicked sense of smell? They go, how did you know that? And it's like, well, because I do too. And that's entirely a brain function. And that's a perfect example of nerve sensitivity in the brain. Donna says, what do you think of exosome regenerative therapy? I have no idea what that is. Let me look it up here. I mean, I have a lot of random research that floats through my brain, so I might have read about it before. Let's see here. Exosome regenerative. Is it a type of stem cell therapy? Exosome therapy is done by IV or direct injection. Or exosomes are powerful elements that can restore cells throughout your body. They enhance cell-to-health communication, which is essential for overall cell health. It's a new frontier in regenerative medicine. Yeah, it's a stem cell therapy. Researchers isolate from mesenchymal stem cells. Oh, this is all research from last year, 2021. Unlike stem cell therapy, exosome therapy doesn't involve using donor cells in your body. Instead, exosomes are released naturally from the cell. These particles are responsible for cell-to-cell communication. They carry genetic info and proteins to cells throughout our body. So they're like the little messenger cells. They release growth factors. That's good. They're nano-sized biovesicles released into surrounding body fluids upon. All right, so you're giving me something else to read about. Let me just check and see if there's been any research with IC. Yes, there has been. Released earlier this year. Released in February. Let's see here. The role of mesenchymal stem cells and exosomes in IC bladder syndrome. Let me just go all the way to the end and let us look at the conclusion. Bladder pain syndrome is a complex and chronic condition in which the exact etiology has not been fully explored. We highlighted stem cells and exosomes as alternative and effective treatments because of their specific features, including powerful anti-inflammatory and immunoregulatory capacities. In addition, they can engraft into bladder tissue and differentiate into key bladder cells. That's good, including the urothelium, to promote bladder regeneration. It can reverse bladder injury regardless of how it's administered. Okay, this looks good. So we've been doing, there's been quite a bit of stem cell and IC research, a lot done by Dr. Elliot Lander down at the California Stem Cell Research Center. That's been going on for at least 10 to 15 years. I absolutely believe in regenerative medicine. The goal of regenerative medicine is to help your body heal itself naturally rather than giving it something artificial. That when you give your body your own stem cells, or they isolate stem cells from another source, there you go. It has the potential of helping. It's all quite interesting. Okay, hold on. There's more research. AMC treats interstitial cystitis with stem cell therapy. Oh, well, duh. Look at this. Here's the next research study, is stem cell therapy. Hold on. Let's go to this one here real quick. This is published out of Korea. Researchers at the urology department of the Asan Medical Center said they have discovered a way to improve the symptoms caused by IC by administering mesenchymal stem cells derived from human embryonic stem cells. Yikes. It's going to cause a lot of controversy. They injected stem cells throughout the CCs. The pain was temporarily reduced in all patients. The pain was temporarily relieved enough that 2 patients did not need to take existing treatments or perform cauterization. No abnormalities were found in blood. So it sounds like they are experiencing what Dr. Elliot Lander experienced, and that is the benefit is short-term, but you have to have retreatment. Embryonic stem cells, obviously, that's quite controversial. Dr. Elliot Lander was doing stem cells derived from your own fat. You started with a liposuction. They took fat from your body. They processed it to what we call stromal vascular faction, which means they just spun it in a centrifuge, broke it up, and they just grabbed all the stem cells and the growth factors, put that back in your own body. And his research showed improvement, but it was not long-term. It was not what we call durable. Okay, so that is going to be a wee bit controversial here in the US.